All right. Thank you, everyone who have logged in, and welcome to Live with Lupus. We need to know about lupus. My name is Lisa Klaslow. I am the Community Relationship Manager at the Lupus Society of Illinois. We're really excited to have everyone on today for this really great informative presentation. I do want to let everyone know that this presentation is being recorded and it will be archived on the LSI website. So if anyone misses a part and wants to go back, it'll be available. Before we get started, a little bit about the presentation. This is an event for educational and informal purpose only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not be substituted or replaced by expert medical care. Before making changes to your medical care, consult your qualified healthcare professional familiar with your medical condition and health status. We'd like to thank our sponsor, AstraZeneca, for letting us have this presentation tonight. Just a couple of things we've coming up this summer. If anyone lives in the southern suburbs, we are going to be doing a lupus awareness night on July 30th. It's at the Park Forest summer concert, so Main Street Nights. Last year we participated as well. We have the best night of the summer. It's the Booze Brothers, so it's great Chicago hits, lots of dancing. So I was definitely up there. We got to present last year. It was really a great night. And like always, we have our annual walk. This year we'll be having one walk in Naperville at the River Walk. So we hope you all can join us on August 9th. If anyone is looking to get more involved, I do need volunteers for the walk and participation, of course. So reach out to me. You can either email me at lisa@lupusil.org or call our office at 312-542-0002, and I'll be happy to help you register or get you signed up to be a volunteer. We are also taking part this fall in a 5K at Governor State University. So they have an annual 5K, and we are going to be one of the sponsors again this year. We did participate last year. It was a lot of fun. So we encourage you to come out as a runner, as a walker. They are offering us an actual 1 mile walk as well. So you can either run, you can bike, you can whatever you want to do, but it's a run, walk, roll. So we hope you can join us on October 26th. The Chicago Marathon, speaking of running, we have a team participating in the Chicago Marathon. We'll have over 40 runners this year. We're very excited. Our team is full, but if you are interested in volunteering the day of or want to learn more about our 2026 team, please let us know. Again, I mentioned volunteers for the walk, but we could also use volunteers throughout the year. So if anyone's interested in volunteering or an internship, please contact us at the office. And then events like this are made possible by your donations. So we do want to thank everyone who does donate and helps keep all of our events like this free for everyone else living with lupus, their caretakers, and their families. So without further ado, I would like to introduce Dr. Aouhab. She is a practicing rheumatologist and is at the Loyola University Medical Center with over 8 years of experience in treating rheumatologist disorder. Dr. Aouhab has special interest in lupus in general and health disparities in particular. She leads multiple research projects on the topic. She looks forward to contribute to education about lupus symptom recognition and early referrals to rheumatologists. So without further ado, I'm going to turn it over to her, but we will have the last 10 minutes roughly for Q&A. So if you do have any questions or anything comes up, throw them in the chat and we'll get to them at the end. So thank you all very much, and I hope you enjoy this presentation.
Good evening, everyone. I'm Zineb Aouhab, one of the rheumatologists at Loyola Medicine, and I'm excited to talk to you tonight about what we need to know about lupus. Lisa, can I share my screen?
Yeah, you should. Oh, yep, there you go.
Okay. Can you see it?
Yes.
Okay, very good. Let's see. Okay. So where did the name, I'm going to start with some introduction and um, origin. So where did the name lupus came from? It was initially invented in the 13th century by a physician, and his name is Rogerius. The word lupus comes from the Latin word of wolf. And that's because this physician noticed that if a wolf bites a person on the face, it leaves a rash that's eroded, like on the picture on the right. And that rash looks like lupus rash. So that's how it came up. It's a very weird way of naming it, but that's the history. This facial rash is characteristic of lupus. It's also called butterfly rash because it resembles a butterfly shape on the cheeks. So what is lupus? It's a very complex disease and it can be defined by different ways, but in general, or to simplify it, it is an autoimmune disease. That means it is a disorder of the immune system. It causes inflammation in the whole body and it can affect any organ, whatever you can think of. The main ones are kidneys, GI, um, stomach, intestine, lungs, heart, joint, skin. That's to name a few, but I'll go into details on the next slide or in the next few slides. So what happens in the body when someone has lupus? So in normal people, the immune system is meant to fight infections, cancers by making some proteins in the blood continuously. In people with lupus, the immune system becomes overactive. That means it's like a bad allergic reaction. And it starts making all kinds of proteins that are not supposed to be made. And those proteins are called antibodies, or we call them autoantibodies, and auto is for self. So that means they're antibodies against self. And they can attack different types of organs, causing potentially organ damage. So some demographics and facts to know about. In general, lupus starts, the typical presentation is, you can keep in mind, is a young woman in her productive age. So between 15 and 45 years of age, it's much more common in females compared to males, so a ratio of 9 females to 1 male. Um, Typically, it would present by episodes of flare-ups, and that means when the disease is active, causing damage. And then there are periods of remission when people feel well and they're back to baseline and the disease is inactive. So there are flare-ups and there is baseline inactive and a flare-up remission. But over time, those flare-ups can lead to organ damage if they're not treated. Flare-ups are unpredictable. They can be triggered by many things. What we know for a fact, uh, stress can be a trigger to those flare-ups. Infections, so if you get like a virus or a cold, that can cause an imbalance in the body and that can cause flare-up. Also, smoking is one of the risk factors for flare-ups and for lupus in general. Sun exposure is another one, and I will talk about that again one more time later on. So organs, I have some pictures here just to keep it very simple. The most common organ that gets affected is skin. So skin, face, or anywhere else, it can be all over the body. Lungs, it can be anywhere, can be in the outside of the lungs, in the inside, in the vessels of the lungs, so anywhere in between. Joints, that's a very common one too, joint pain, or you can see swelling of the joints, stiffness in the morning. Brain, it can cause um, mental disorders or what we call psychosis, or depression, or stroke if it's serious, like blood clot there. Kidneys, very important organ that we screen for all the time in patients with lupus. They can get inflamed, and if they're not treated, they can shut down. They can lead to kidney failure requiring dialysis. So very important to screen. GI tract, it can be, again, anywhere. It can be inflammation of the intestine or the stomach. Heart can be the lining of the heart or inside the heart. So different parts of the organ too. This is not comprehensive by any means. There are so many other organs that can get affected depending on people. So what are the first symptoms of lupus? In general, generally speaking, Lupus is it usually starts with very non-specific symptoms, which makes it hard to diagnose early. So initially, people can just have some feeling fatigue, which is a common thing, um, some weight loss, some rashes, like a rash on the face, or joint aches or pains, swelling in the legs. It can be headache, as we spoke earlier about, if it affects the brain, oral ulcers, so sores in the mouth, being sensitive to the sun. So you go out, all of us, if you go out in the sun for a certain period of time, or like an hour or hours, you'll get sunburn, right? That's not what we talk about in lupus. People with lupus are very sensitive to sun exposure. And I mean by that, if you drive in a car for like 5 minutes, or you walk for 5 minutes outside and it's sunny, you can get a rash that lasts for like a week or two. And it can be painful, can be a rage. So that's the difference. Not every, like, people that are fair skin, for example, and they go out in the sun uh, all day and they get sunburn, that doesn't really count as photosensitivity. Um, Other things like fever, chest pain, so if the heart or lungs are affected, or even like the ribs, so joints there, it can cause chest pain, shortness of breath, depending again, could be heart or lung, color changes of the fingers and toes. That's a very common thing. So fingers here, some people with, in general, this is not specific for lupus, but it can happen with any other autoimmune disease, but the finger palms here or the palm of the hand, they can turn blue when exposed to the cold, and that can be very painful. Usually people will tend to go inside or warm them up or run them under hot water to reverse that pain and the discoloration. So that's something we call Raynaud. That's the color change of the fingers. Seizure is another one. If the brain is inflamed, blood clots, stroke. This is to name a few. And lupus can be divided into multiple types. The most common one is systemic lupus. And that's the one I've been talking about all along. But there are some other subtypes that I'm gonna touch on briefly. The second one is discoid lupus, and it's mainly skin involvement. That usually stops there, and it has a more benign course compared to systemic. Systemic means it's all over the whole body. Discoid is more just skin. The third one is drug-induced lupus, and that's lupus that's due to some medication. So someone starts a medication for a different reason, for something else, and then they start developing those symptoms of, let's say, joint pain and rashes or fever. And then we realize it's the medication causing that. And obviously here, the common sense is to stop this process, you'll have to stop the medication, the culprit medication. Um, Another type of lupus is neonatal lupus, and that's when a pregnant woman with lupus or without knowing she has lupus, but she has those proteins we talked about in the blood, they can transfer to the baby and cause a newborn to have symptoms of lupus. Mainly would be, again, rashes or counts being low when we check blood tests. So that's another type. This type of lupus has, in general, good prognosis, because if it's due to the proteins that came across from the mother, then typically when the baby gets to 6 or 8 months old, they get rid of all of those proteins and the symptoms resolve. And the last one is overlap syndrome. That's when lupus overlaps or is associated with another autoimmune disease. For example, someone has lupus and rheumatoid arthritis at the same time, or lupus and scleroderma at the same time. So when you have more than one disease, we call it overlap syndrome. So here, just again, I like visual memory for people, so I have a lot of pictures here. This is, again, just explaining why we call it systemic. It's because all the systems can get affected. And examples here, skin, if we start from skin and we go clockwise, skin, the rashes, discoid rash, and then the brain, neurologic symptoms, seizures, psychosis, and then the lungs, spleen, joints, kidneys, and the blood, where there are so many tests we're going to talk about that we can check, either like for the immune system or some abnormal findings of counts like anemia, like low platelets. And these are pictures of discoid rash. You can see that on top picture, the rash, when you see that little kid here, when you look at the rash on the cheek, there is a center. The center of the rash is clear and the edges are red. And that's how discoid rash presents, because it starts from the center, then it spreads to the edges, but the center heals first. So then you get that clear discoloration or scar of the center. Discoid lupus is known for scarring. So you see the bottom picture, that's pretty extensive discoid rash. And you can see again, the center is lighter because it has healed with scars, while the edges continue to be inflamed and they're more pinkish. And the typical areas for discoid lupus are head, cheeks, behind ears, or inside the ears. It can affect the scalp as well. The good news about this type of lupus, although sometimes it can be frustrating because it's the skin and the aesthetic, but it has a good prognosis, because most people, like over 90% of people with discoid lupus, will not develop systemic lupus. They will just have the skin rashes, and if they're treated, that can improve, but they don't progress to like the internal organs that we talked about earlier. But about 10% of them may progress over time. So we do monitor those people as well, to make sure that nothing progresses. And if it does, then we treat it early before it causes any organ damage. Drug-induced lupus, so the other type, the third one that we talked about. Again, most of the time it would be rashes, joint pain, sometimes fever. And once you stop the medication that caused this, typically the symptoms will resolve on their own. It's rare that we have to give more medications to this type of lupus, because it's self-limiting once you stop the medication. Another example of neonatal lupus, the lupus in the baby, usually again rash, resolves by 8 months or so. Also, for those babies that had the antibodies or those proteins transmitted from the mom, those proteins can go to the heart and cause irregular rhythm, or what we call heart block, that may require a pacemaker. So that could be a serious condition. And for women with lupus or that have those antibodies, we monitor them very closely during their pregnancy. They are monitored by high-risk OB-GYN as well, because those people they're specialized in high risk, and they know what to monitor for in case something happens during the pregnancy. They can intervene in time to prevent complications. And overlap syndrome, this is just like giving you more pictures so you can remember what I talked about in that previous slide. So lupus can be associated with rheumatoid arthritis, like the picture on the bottom right. You see those deformities of the hands are classic of rheumatoid arthritis. The other picture on the left is scleroderma, skin tightening, and that can be also sometimes associated with lupus. Lupus can also be associated with muscle inflammation. We call it myositis. This is not comprehensive. Again, there are multiple other associations that can happen. How do we diagnose lupus? Very challenging. To give you an idea, it can take up to 4 to 6 years and up to 3 physicians before lupus can be diagnosed sometimes. So that's because, as you can tell from what we've been talking about so far, it can be very diverse and very different from one person to the other. So sometimes, primary care physicians or emergency care doctors, they may miss the diagnosis because they're not familiar, especially if the first symptoms are not specific for anything. And usually that's the case. The first symptoms are vague, and they don't suggest any diagnosis initially. We call lupus the great masquerader because it can simulate anything, basically. So how do we diagnose it? So as you can notice, we've spent like the first 20 minutes just talking about symptoms. That tells you that lupus is mainly based on history and physical exam findings. Blood test comes in last. It only supports the diagnosis if we have a strong clinical suspicion. And what are those labs and what do they mean? And I know, whoever had lupus gets overwhelmed with the amount of tests that we take and it can be overwhelming at times. So let's start and let's keep it simple again. Initial workup, we do an autoimmune disease panel, we call it. And it's a test usually that has a number of specific antibodies that can tell us if there is one or two of them, if there are a couple that are positive, they can tell us a little bit or specify what we're looking for. They can point towards something that we can focus on. And then other tests that we do. So as you can tell, we want to screen for those internal organs to make sure they're functioning well, they're not inflamed, they're not affected. So comprehensive, the second test is comprehensive metabolic panel, and that checks for liver and kidney function. The third test is complete blood counts that checks for white count, red cells, and platelets. Then very important, we check for urine to check to make sure that the kidneys are not inflamed, because if they are, then usually that starts with some blood in the urine and protein spill in the urine. So the last two tests are for urine. There is the battery of autoimmune tests that we check. I don't think you need to remember any of those names because it's variable from one person to the other. Usually here, we only get one or two tests at most that are positive. Rarely for people that have very strong autoimmune background, they can have more than a couple, but in general, there are only one or two that are positive. And the first one is the one that I'm sure all of you know about. It's anti-nuclear antibody, and that's the first test that we screen for. We do that because this test, if it's negative, it actually tells you you don't have lupus. Now, if it's positive, and that's where we see a lot of patients referred by primary care doctors, is when there are some non-specific symptoms and they check this test and it comes back positive. Now, to keep it just like a brief idea I'm going to touch on, that test is not specific for anything. It can help you make sure you don't have it if it's negative, but if it's positive, it doesn't tell you much. It just tells you that there may be something that we don't know. And then after that first test, that's when we do that battery of tests that you see that are following it, all on this page here. So anti-nuclear antibody test, again, I talked about most of this. And you can have it a lot of times. People can have this antibody and it's false. We call it false positive. That means it can be positive in the blood when we check it, but it doesn't mean anything. So here are some situations I've listed that can cause this antibody to become positive in the blood, and it doesn't mean that it's going to cause an autoimmune disease. So if a person has another autoimmune disease, let's say someone has autoimmune thyroid disease, like Graves' disease or Hashimoto's, that autoimmune thyroid disease can cause the person to have a positive ANA. So if we check it and if it's positive and you have a thyroid, that could be related, and that's all there could be. It's not always the case. I'm just saying sometimes it could be the only reason why it's positive. If someone has a relative with an autoimmune disease, any autoimmune disease, you're more likely to have a positive ANA test. Some medications, and I already talked about drug-induced lupus. So some medications can trigger this ANA test to be positive. But if there are no symptoms from the positive ANA, we don't necessarily stop the medication. Age and the gender. So ANA is usually false positive typically as we grow older because we're exposed to more like triggers and like infections, like smoking exposures, even secondhand. So things like that can trigger an ANA. And then women are more likely to have a positive ANA than men. Viral infections. So positive ANA does not always equal lupus. And we see a lot of patients coming in very stressed out that they had a positive ANA thinking they have lupus. And after we do our workup to confirm it, the workup does not show anything, and then they get reassured. So ANA is positive in 99%, on the other hand, of patients with lupus. So everyone with lupus should have a positive ANA pretty much. So if someone has a negative ANA, she or he is unlikely to have lupus. But if it's positive, again, you have to do more testing. You have to do more work to figure it out. Double-stranded DNA is another antibody that's specific for lupus. So this one, on the other hand, if it's positive, we take it more seriously because this is telling you that there is an antibody in the blood that can be causing damage down the road. So specific to lupus usually goes high when the disease is active, and it can go low when the disease is inactive. So we measure it. It's a measure of disease activity. So this one we repeat periodically upon checkups to make sure that it correlates, or if it becomes positive, for example, after it became negative, we have to be more careful. Maybe there's a flare-up coming up. Should be negative or low titer when the disease is controlled and not active. Complements, I'm sure all of you are familiar with that. Those are proteins that can go low when lupus is active. Remember, I talked about double-stranded DNA just in the previous slide, and I said it goes high when the disease is active. These proteins, complement 3 and 4, they go low when the disease is active because they are consumed. So consumption. So they get depleted. And it's also a measure of disease activity. Claudin risk tests. So about 1 in 3 patients with lupus can have another type of antibody that could cause blood clots. And if that happens, then there's another disease we call antiphospholipid syndrome, and that's how we diagnose it in patients with lupus. If you have a blood clot, in addition to a positive blood test, and I listed 3 of them down there, lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein. If any of those are positive, in addition to blood clot or blood clotting events, then that makes a diagnosis of antiphospholipid syndrome. Another symptom that can be associated with antiphospholipid syndrome is miscarriages. Not any miscarriages. Usually it's a second trimester miscarriages or multiple first trimester miscarriages. So just detailing here what the comprehensive metabolic panel means, and that's one of the tests that we check at diagnosis and upon follow-up. This basically, those are electrolytes in the body plus kidney function, which is the creatinine there and the BUN, and then the AST, ALT, albumin are all liver tests. Then we check counts. We already talked about that: white count, hemoglobin, platelet. Urine tests, so we look for proteins, we look for blood, for sugar, for infections, because people can get urinary infections too. And then the protein creatinine ratio is the amount of protein that's secreted in the urine. Normally, we should have very, very minimal to 0 protein in the urine. So if it's high, then we become suspicious. If there is suspicion enough for a kidney being involved with lupus, which is called lupus nephritis, then a kidney biopsy would be indicated most of the time, because kidney biopsy means go with a needle and take a piece of the kidney to analyze it and see what type of inflammation. There are 6 types of inflammation in lupus. So you can't really tell which one that is unless you do a kidney biopsy. And this also guides the treatment, because type 1 is not the same, or class 1 is not the same as class 2, not the same as class 5. They have differences in treatment indication. So it is very important to have that piece of information. But this is only if we suspect that the kidneys are inflamed based on the urine test and kidney function. So a lot of us always ask, oh, how often do I need my blood tests repeated, or I'm getting them too often, why is that? So in general, your lab tests are checked every 3 months to assure that they are within normal limits. And those are usually double-stranded DNA, complement, counts, kidney function, liver function, urine tests, exactly what we talked about. And if there is a concern, or if the patient feels that they're not feeling well, there may be a flare-up, we check those even more frequently to make sure that, if there's something in between, we catch it again in time. So medications used to treat lupus, it becomes complicated, but I try to really simplify it as much as I could here. Depends on the symptoms. So we'll start from the least important to, or the weakest to the strongest, and so forth. So anti-inflammatories or NSAIDs or anti-inflammatory medications are things over the counter like ibuprofen, Motrin, Aleve, Advil, naproxen. Those can be used for joint pain in general, and they can help for the most part. And then there are also stronger anti-inflammatories called corticosteroids, like prednisone, Medrol, Kenalog. There are multiple brand names out there, but those are strong anti-inflammatories. So that would be second step. Or if there is something serious that cannot be treated with anti-inflammatory, the NSAIDs alone. And then we go to the medications now that we use for long-term for immune regulation. The first one is the anti-malaria drug like Plaquenil or hydroxychloroquine. This, I tell people with lupus, it's almost like a vitamin to people with lupus because it treats so many things and it prevents so many complications. So Plaquenil is a really good medication for joint-related issues as well as skin issues. So here we at least have two organs, right? And then it has also been shown to prevent internal organ involvement, for example, kidneys. So kidney disease can be or may be prevented by just taking Plaquenil. Quinacrine is another medication that usually we use if there is a skin problem, and Plaquenil or hydroxychloroquine is not enough to control. And then the stronger medications here, immunosuppressive medications. So these will work by modulating the immune system, and these have they kind of lower the immune system, so they have a little bit more side effects potentially. First one is mycophenolate or Cellcept, azathioprine or Imuran, methotrexate, leflunomide or Arava. Cyclophosphamide is a very strong medication. This is rarely used nowadays because we have many other alternatives. This one has significant side effect profile, so that's why it's less favored. We only use it if there are life-threatening manifestations. So we feel like the organ will shut down completely or something urgent needs to be done. That's when we think about that one, cyclophosphamide. Then there is cyclosporin, there is tacrolimus. For the most, these are all pills for the most part, except Cytoxan. It can be pill or an intravenous, so like via the blood. Okay, okay. Sorry about that. Biologics like belimumab, Benlysta, or rituximab, Rituxan. So those are newer medications that can be used for multiple indications. Belimumab is really good for skin disease as well as joint disease. Rituximab also for joint, for skin. Now, Benlysta has been also approved for kidney disease, which is a good thing. It's another option that we have for patients, which is great. And then I'm going to add I have another slide on newer medications, even newer than these. And I'll get to that toward the end. So we talked about anti-inflammatories here, like ibuprofen and Advil and things like that. The concern with those, it's over the counter, so they can be self-administered. However, they can have potential issues. They can raise blood pressure. They can cause kidneys, heart issues. So you have to be careful when you use over-the-counter medications. If somebody has already a heart problem, it's not recommended to take those anti-inflammatories, for example. High blood pressure, you have to monitor it if you take them. They can also cause increased risk of bleeding, so stomach bleeding. So they should be also avoided in people that take blood thinners. And we talked about the blood clotting disorder. So those people, some of them may be on blood thinners, so you don't want to take ibuprofen with that, for example. Gastric ulcers, another thing. Corticosteroids, very commonly used. We call them, so brand names like prednisone, prednisolone, Medrol, Solimedrol, Kenalog, Depomedrol. So there are so many names. They're given topically, meaning like creams for skin, for example, or orally like pills, or injection in the muscle, injection in the joint, or IV. IV usually, or intravenous usually for people that are very sick. Usually obviously that would be in a hospital setting. If there is a significant organ involvement, as I said earlier, and we worry that either like it's life-threatening or organ-threatening problem. So usually the first line therapy in very active disease or flare-ups, often they're life-saving. So it is, I mean, they are good. We cannot ignore that. We have to admit they can save lives. However, they have to be weaned quickly because they can have potential side effects. And that's why we call them frenemy. Frenemy, I like that acronym because friend is for friend. So it's our friend initially. It can save lives, but then it becomes enemy if you take it for a long time. That's why we have those battery of tests, which are, of medication alternatives I mentioned on that list earlier, previous slide, to substitute for the steroids if we need them long term. Potential side effects for steroids: high blood pressure, diabetes, osteoporosis, bone weakening and fractures, cataracts, weight gain, infections, insomnia. So there's so many side effects, and it depends on people. Some people are not very sensitive to it, and others are very sensitive. So it varies. Plaquenil or hydroxychloroquine or quinacrine. This family of medications was discovered by coincidence. Very interesting story. When people in World War II, the soldiers that took Plaquenil for malaria had less joint pain. So that was an observation. And then from there, Plaquenil started getting used for joint symptoms and skin, and it was adopted now and one of the first line treatments in people with lupus. It can also help with constitutional symptoms like fatigue and aching. In general, very well tolerated, very few side effects. The main one to be aware of is the visual or potential eye issues. And we just stress the importance of regular eye exam. Eye exam, we only do it once a year. We only do it once a year. So I know it's cumbersome eye exam, but in general, it's rare that you need to do it more than once a year. And it's very important because it can screen for any changes in the eyes that could be related to Plaquenil, and that would lead to just stopping the medication before you even have any eye issues. And that usually prevents progression of that problem. So immunosuppressive medications, I already talked to you about them. In general, the main concern with them is that they lower the immune system, so they can cause issues such as infection. That's the main one. They have different profiles depending on the medication, so that would be decided on a one-to-one basis. Needs a long discussion with the physician that will be prescribing them to make sure that both sides are comfortable with it. So biologics are medications that are advanced. They're like more targeted. They're specific to certain molecules in the body. So Benlysta or belimumab is the first approved drug for lupus in over 50 years. So that was revolutionary for lupus. It's used for skin disease, for joint disease, and can help with fatigue too. It's given monthly, once a month, IV medication. So it goes through the IV. But now we also have subcutaneous formulation, which is like a pen, and you can just give it by yourself at home, and it's simple. And that one is it's more frequent than that. So it's every week or so. Rituximab is another medication that's not approved for lupus, but has been approved for severe disease, especially for people that have like abnormal counts, like platelets that drop or anemia that's refractory. Rituximab can be really good for that. It's an IV medication as well, and it's given every 6 months. Newer biologics. So now we have something called anifrolumab or Safnelo. That's another biologic that's given also through the IV once a month. And then we have tacrolimus, which is a pill, and voclosporin, or another name for it is lupus. And it's another pill that can be used for like kidney problems, and as well as in general, kidneys would be the best indication for that one. Adjunctive measures. So we talked about all of this battery of medications, but there are certain things that are very important and basic things to know about that can prevent flare-ups that would require a significant amount of medications. So we talked about earlier about sun being a trigger for flare-ups. So people with lupus should avoid sun exposure. If exposed to the sun, they should apply. Sorry. If exposed to the sun, they should apply sunscreen with an SPF of 30 or higher and broad spectrum every 2 hours. They should also undergo appropriate screening for like anybody else for with pap smears and mammograms. They should also have regular dental and eye exams. So dental exam because of dry skin. Sorry, I'm sorry about this disruption. Sorry about that. Um, they should have regular, so we're talking about dental exams because a lot of people have dry mouth and that can uh, lead to cavities and losing teeth. So we do recommend a regular dental exam as well. Eye exam, again, now there are two indications for it. So dry eyes, that can also happen in people with lupus, as well as monitoring for plaquenil. Remember, we talked about plaquenil or hydroxychloroquine that can cause eye issues. So two reasons to see the eye doctor on a regular basis. So other things to be aware of, because there is a chance that we're going to use immunosuppressive medications that will lower the immune system and potentially cause infections. It is important to get vaccinations as indicated. In case there is a need, then you're protected against certain infections, at least the ones we have vaccines for. Now, other things like vitamin supplements, for example, calcium, vitamin D are important. First, vitamin D, if it's low, that can cause flare-ups in general, can cause more aching. And then if for people that take corticosteroids like prednisone or steroids in general, that can lead to, well, I already mentioned earlier, it can lead to bone weakening and fractures, and calcium vitamin D can help prevent some of that. People with lupus in general should monitor their blood pressure and blood sugar, especially if they're taking steroids, again, because corticosteroids, they can increase blood pressure, they can increase blood sugars. So those are important things to keep an eye on. What else? Lifestyle modifications. So common sense things, just common sense. You want to stay active. You want to maintain a regular physical activity program, eat healthy, well-balanced diet. You would want to avoid sugar-sweetened beverages, eat more fruits and vegetables. And all of these measures will just keep you healthy. So it helps in more than one way. It will keep you healthy as well as prevent some other issues that can happen along the way, like high blood pressure, diabetes, obesity, high cholesterol, because all of those are risk factors that can, or factors that can lead to decreased, um, to increased mortality down the road and morbidity. You don't want to add that to lupus. So then you get more than one risk factor. Habits to change, strongly recommend against smoking, because smoking, either like first-hand or second-hand, it can lead to flare-ups of lupus. Sun exposure, I think we talked about it quite a bit so far. And then obviously you do not want to stop your medications without consulting with your doctors, because those medications are meant to help prevent certain complications. You don't want to stop them by yourself without discussion, because then that can lead to serious complications and flare-ups and damage. And in addition to all of what we talked about, it can be really challenging how to navigate healthcare system, especially if you need to see multiple specialists. So just some suggestion there. You may consider a diary where you can keep track of all your symptoms, and that makes it easy when you go see your physician. You can just read through your symptoms or have a summary that makes it easy for you and for the physician and makes your visit productive. You want to see your doctor regularly, even when you're feeling well. So they can tell what is your baseline and how you feel when there are flare-ups. Be prepared for the office visit. Write down questions, because people, you can be organized as much as you can at home, but when you're in the visit, you feel sometimes rushed, or if you didn't sleep well or you're tired, then you forget and you feel like you missed the opportunity to get all your questions answered. And then be honest with your provider. Don't keep back any information. If you're taking supplements, herbs, over-the-counter medications, you want to mention them, because sometimes, although you may not think so, you may think it's safe because they're over-the-counter, but sometimes they can interfere with your prescription medications and they can cause side effects. And share any concerns. Try to have open discussion, and you want to obviously, try to have some connection with your treating physician, because that for sure would lead to a better outcome. Other suggestions, you could consider bringing a family member or friend with you to the office, because having a fresh pair of eyes and ears may help sometimes. Keep things on track. You can have, you may have name information of other specialties to help communicate. So for example, if let's say you're seeing an eye doctor outside of the facility where your rheumatologist at, it probably would be helpful to give that information, that card or fax number, to your physician, so they can communicate, make sure that the eye doctor doesn't have any reservations as of whether you should be continuing hydroxychloroquine or plaquenil, for example, or not, and so on. Ideally, you want to try to keep all your physicians in the same system so they can be easy communication, but if you can't, it's fine. You just need to provide the information so they can communicate together. Take also, when during your visit, you can take notes on your, either on your phone or a diary. That helps you remember when you go home. Also, always ask questions if you don't understand, anything. And then always good to, at the end of the visit, if you get a chance, you want to summarize what you understood from your visit before leaving. That way, you double check with your provider that all the information has been communicated clearly and there is no misunderstanding. So how often should I see my doctor? It is very variable, because it depends on how bad the disease is and how active it is. So typically, if patients are stable, we see them every 3 months. That's the recommendation. But they can be seen less frequently, let's say every 6 months, if they've been quiet for a long time. But in general, the rule is 3 months. Obviously, if they're sick, or if they have a flare-up, they should be seen more frequently than that. So bottom line, your treating physician will be the one deciding on how frequently he would want to see you in clinic. Stress and lupus. Stress is very important, and I know I'm asking for the moon, but really controlling stress can help prevent so many things in general with lupus. It would help prevent stress, makes your medication more effective. So it's very hard. Nobody lives without stress. That's a fact, but you want to try to control it to the minimum possible. So we know that studies have shown that stress can trigger lupus flares, because the immune system becomes more active when during episodes of stress. Stress can be due to major events, or it could just be daily activities escalating with time, or dealing with a chronic illness by itself. That can make you tired afterward and frustrated, and that can cause imbalance and stress in the body. Stress, besides causing flare-ups of lupus, it can cause or make the high blood pressure and diabetes difficult to control as well. So then you add more risk factors for complications. Stress can lead to depression, in addition to chronic disease like lupus that can lead to depression. So you want to at least control the stress so you can deal better with the disease and cope with it in a better way. Depression is a very important point too here in lupus. You want to share with your physician any concerns that if you're feeling depressed, because it's not uncommon. And that should be treated appropriately too, so it doesn't lead to adverse events. How do we manage stress? There are many ways that you can use to tackle stress. Make a list of priorities, so you don't keep thinking about it all the time. To-do list, stick with your plan, make time for fun. Massages, meditation, discuss this with your healthcare provider, see if they have better options. find support groups because people can share their experiences, makes it more soothing. Um, um, ways to tackle stress can be, there are many ways. Biofeedback is another way. You probably will have to try more than one until you find the one that works best for you and then stick with that. Another thing that I should add there is also exercise. Exercise regularly can help lower your stress level. Good sleep, you can tell that there is an endless list of things that can be done. And how to obtain more information about lupus. So first thing, you want to start with your provider. You want to ask all the questions, get all the resources you can. We usually have like handouts for patients with simple words or explanations um, to read and learn about lupus and medications and all of the things we talked about so far. Lupus Society of Illinois is a great resource that's local and always easy to get in touch with. And there is their website here below if you need it. And I think we kept it on time. So we have 9 minutes for Q&As. Happy to answer any, and thank you for your attention.
Thank you. That was a lot of really great information. So yeah, if anyone has any questions, you can throw them in the chat now. Um, just kind of listening through, I had a question about discoid lupus. I know, we always hear SLE, that's the main one that people call about. If you have discoid lupus, are you still seeing the rheumatologist, or is that just like a dermatologist? Like,
Yeah, that's a great question, Lisa. Um, so discoid lupus in general, they start with the dermatologist because there is a skin problem. I mean, first thing, common sense, they're going to go see a skin doctor. Most of the time, those patients will be directed to us because dermatologists are familiar with the fact that it could be related to, sometimes it can progress to internal organs. So they do refer them to us, so they end up seeing us. They probably will see the dermatologist more because the skin needs to be under control, but we also help with the medications because not all dermatologists are comfortable with prescribing those medications. So we cooperate with them. So we work together to get to the best a mutual decision along with the patient.
so how, I guess then my next question would be like, how do you kind of work that out? Do you, as a patient, try to get your doctors to know each other then? Or,
Right. Well, that's what I was talking about earlier is sharing the information. So if you have a dermatologist, you want to share the information with the rheumatologist and vice versa so they can communicate. At least notes should be sent from one to the other each time you see them. So there is an update on the plan. And if there's any recommendation, then the other person should be aware of it.
got it. Okay.
And if they're in the same institution, that makes it even easier because you can just check through their note. But if they're outside, then it's not hard. We always um, request the medical records, and it's not hard to get them.
Okay. Good to know. Does anyone have any questions to throw in the chat? One more question that I had is, I know you said Plaquenil, if people have eye issues and you're starting to have see damage from the Plaquenil, I know you mentioned getting off of it, stopping Plaquenil. Is there another alternative, or because I know Plaquenil really does help? What
Mhm.
happens then if you can't take it?
Right. So then there are the other medications I mentioned afterward.
Okay.
Um, there are many, so there are many options that we could try instead of Plaquenil. Plaquenil has a very good side effect profile. It's very, very minimal risks in general. That's why, and great benefits. That's why we go for it. We go for it first, but then if we can't choose it, there are the alternatives like methotrexate, like Celsat, like um, leflunomide, depending on what the manifestations are.
Well, we've had a couple questions pop up and they're all on Plaquenil. So I've been on Plaquenil for almost 20 years. How concerning do you recommend in regards to probability of negative effects of long-term use?
So that risk that I mentioned about Plaquenil causing eye issues is not really raised, although we keep talking about it from first day we prescribe it. It's not really raised until people are on it for at least 7 to 10 years. At that point, there is a 1% chance of it happening. So it's extremely rare. Now, if patient needs it, they can be on it as long as they need to, as long as their eye exams are on time and the eye doctor does not see any changes in their eyes. In general, for someone who's been on it for 20 years, depending on how bad the disease is, at some point, I try to at least lower the dose to decrease that risk because it is dose dependent. And we do calculate the dose based on weight to make sure that we're below the dose that could lead to eye issues. But I try sometimes, if the disease has been inactive for many years, then I try to lower the dose to keep it at minimum. That decreases their chance of the eye problems.
I've been taken off Plaquenil because my doctor said I have Plaquenil toxicity because of my skin on my legs are black in many places. Is that true?
Plaquenil can cause darkening of the skin, especially of the arms and the extremities. It can do that. However, that side effect is not like life-threatening. So sometimes if the patient is comfortable with it, it's more for aesthetic reasons. If the patient is comfortable with it, sometimes I continue. If they're not, then I would stop it.
Would you recommend Plaquenil over Celsep?
There are very different indications for both. So Plaquenil is more for joint and skin. So mild manifestations, Sussept would be more for either severe skin manifestations that is not controlled on Plaquenil alone, or mainly would be kidneys or liver or some internal organs that are serious. And usually those two medications are combined
Okay.
together.
The person that had asked the question about the toxicity said she's been on the Plaquenil for 36 years.
I mean,
Um,
it can be continued as long as it's needed, and again, as long as the eye exam is not concerning.
will the doctor who diagnosed me be the same doctor who treats my lupus?
If you're comfortable with that in general, that's a rheumatologist, I would assume. So rheumatologists normally, yeah, they would diagnose it and continue treatment unless there is something else. I mean, I don't know exactly the special situation, but if it's a rheumatologist, then normally that's the person that will treat.
Okay. I have fibromyalgia as well as lupus. How common is that?
It's very common association with lupus. Fibromyalgia, however, is not an autoimmune disease. It's more of a myofascial pain, but it's very commonly associated with lupus.
And does a rheumatologist treat that as well then?
So it depends. This is a variable, there's a variable answer to that. Some rheumatologists, they would treat both, and others, because fibromyalgia is not autoimmune, others may defer that part to the primary care doctor because it's more of a pain control, but they will treat the autoimmune part, which is lupus. But others will treat both, so it's variable.
Okay. Any more questions? I think that's all I come through.
Those are all great questions, by the way.
Yeah, I think, and we often find that people who have had lupus for 20 plus years still have, like, they just don't have the time with their doctor. And that's why we feel these talks, even though, it's to live with lupus, they've lived with it for a long time. There's
Right,
still a lot of unanswered questions or things that,
right.
so
Well,
that's
we're
why,
all learning every day.
yes.
So,
And
yeah.
then one person did write, I'm starting to have dark spots on my skin as well, but derm said it says no cancer. What am I supposed to do with that?
I'm not sure I know the answer to that. Um, I don't know what they diagnose it with. And you may want to, it depends on what they call it. If they're confident with their diagnosis, then they will tell you what to do. They'll be the ones telling you what to do. But if they don't know, sometimes they take a piece of the skin, a biopsy, to see what exactly is going on in those spots.
Got it. All right. Thank you for the information. Very informative. And she wrote the
My
last,
pleasure.
yeah, she said the last question was a joke. Okay.
Oh, I see. Okay. All right. That's a nice way to end the talk.
Right. All right. Well, thank you so much. We really appreciate your time. Um,
My pleasure.
And this presentation was great. Yes, great presentation. Thank you. We also want to make sure we thank AstraZeneca again for sponsoring tonight. So thank you, AstraZeneca and our partners there. I did also want to just remind everyone that we do have our walk coming up on August 9th. We hope everyone comes. It's at the Naperville River Walk. So we're just doing one this year. So we'd love to see everyone out there. It's about 11 weeks away, I think, something like that. We're definitely counting down. We're very excited for it. So we hope everyone comes out. And we hope to see you all soon at our next educational event, which we are working on one for a Spanish one in September. So if anyone is for Spanish speakers, it's on cutaneous lupus. So we will have that posted soon. So thank you all so much. We hope
There you go. That's the answer to the last question.
log in Spanish, right? Get all the
Yeah,
information.
right. All right. Thank
All right.
you.
Well,
Thank you,
thank you,
guys.
everyone. Have a great night.
You too. Bye-bye.
Bye.